Hello and welcome to the first in this series of clinical cases for second years. Today we're going to be looking at the foundation block and the 16 cases that we were taught about throughout the first week of this second year. In this particular video we're going to look at around 10 of the cases, and in the next video in part 2 we're going to look at the final 6. So to start with, we'll look at respiratory distress syndrome. So this is a condition that occurs in preterm babies due to the lungs not being fully developed. So when we say preterm, we mean a baby that's born before 37 weeks. So 37 weeks is considered full term. Now, in terms of the earliest viable baby, the rule of thumb is around 23 weeks. However, it has been known in the past that babies have been born at around 22 weeks, and with severe medical intervention, they've been able to survive. So really, this syndrome here, respiratory distress syndrome, is caused by the surfactant levels not being sufficient enough when the baby's born. So surfactant levels are affected by primarily gestational age, but they can also be affected by genetics and beta-adrenergic drugs. So surfactant synthesis begins in around weeks 17 to 26, and the whole aim of surfactant is to reduce that surface tension in the lungs. So it really does have its consequences if the baby is born when it is not at a sufficient level. It normally occurs in babies that are born before 28 weeks gestational age, so you can imagine how young that is. However, what we need to bear in mind when we're thinking about the lungs is that actually lung development doesn't stop when we're born. Lung development actually continues onwards until we're around 18 years old in terms of the development of those final branches. So next is bronchopulmonary dysplasia, and this is quite linked in to respiratory distress syndrome. So bronchopulmonary dysplasia is a chronic lung disease in which premature infants, usually those who are treated in hospital with supplemental oxygen, require long-term oxygen. Now, the important thing here is distinguishing between old bronchopulmonary dysplasia and new bronchopulmonary dysplasia. So old bronchopulmonary dysplasia refers to an injury or some kind of damage to the lungs, whereas a new BPD refers to something that's interfered with the development of the lungs, not an injury as specific. In terms of consequences, unfortunately, it does result in significant morbidity and mortality. And obviously feeding problems are sometimes difficult as well in these infants due to the prolonged intubation that they must undergo due to the lack of oxygen. However, in terms of treatment of this condition, steroids treatment is usually pretty effective. However, the risks of treatment must outweigh the benefits in order for them to be prescribed. Next, we looked at cerebral palsy. So cerebral palsy is a lifelong condition which affects movement and coordination. And there are 4 types of cerebral palsy, which you can see on the bottom right-hand side of the screen here. Spastic cerebral palsy is the most common, occurring in around 80% of cases. So if you're going to learn about any in particular, that's probably the one to focus your attention on. Symptoms of cerebral palsy really does focus around movement and coordination, like we said earlier. So things like weak arms or legs, or seeming too stiff or too floppy. Also, walking on tiptoes is quite a distinctive sign of cerebral palsy, difficulty with walking due to those weak arms, weak legs. What causes cerebral palsy? So this could be due to bleeding in the baby's brain or reduced blood at any point. An infection caught by the mother during pregnancy is also quite a common cause, and on a more rare kind of terms, meningitis or a serious head injury can also cause cerebral palsy. In terms of treatment, it's not quite a straightforward drug treatment. Physiotherapy is usually the most effective in terms of helping the sufferer of cerebral palsy gain that strength in their legs again to be able to walk, but also in terms of speech therapy as well is proved to be really useful, as well as occupational therapy. Next, we look at periventricular leukomalacia. So this is a type of brain injury that's most common in premature babies, particularly at those that are born at a low birth weight. So periventricular leukomalacia affects the white matter of the brain and causes the white matter to soften, which leads to issues in terms of neural connection. So if you think about what the white matter does, in a general kind of sense, the white matter is responsible for transmitting those messages from nerve cells between the different regions of grey matter. So therefore, damage to the white matter can cause problems with movement and other bodily functions. The most common symptom is cerebral palsy. So again, what we're thinking about here is links. So how early we link bronchopulmonary dysplasia to respiratory distress syndrome. Here you can link cerebral palsy to periventricular leukomalacia. And the really important thing here is that approximately 60% of infants with periventricular leukomalacia are also diagnosed with cerebral palsy. So there's a significant link there between the two. Usually, however, this condition is not obvious at birth, and it actually becomes evident within the first 1 to 2 years of life, okay, with the symptoms that it presents with. Children with periventricular leukomalacia as well may also suffer from learning disabilities or visual problems also. In terms of cures, treatment, unfortunately there's no cure for this condition, however management's the best way to go, and physiotherapy goes a long way, unlike the case of cerebral palsy. Next is Spina Bifida. Now this one kind of is a little bit of a crossover with neurosensory, which will be covered in later videos. However, Spina Bifida is a defect of the neural tube. So the neural tube is really important because it's what goes on to form our central nervous system. So central nervous system, we mean brain and spinal cord. Okay, now the neural tube normally closes by week 4 of the pregnancy, by week 4 gestational age, and the anterior or the ventral end of the neural tube usually closes first around day 25, and then the dorsal end or the posterior end closes around 28 days. So spina bifida is a defect of that neural tube where it doesn't actually start, where it doesn't close in the way that it should do, and it leads to defects in the spinal cord and the bones of the spine. What's really important is there are actually 3 types of spina bifida. Okay, so we have this first type here, myelomeningocele, then we have meningocele and spina bifida occulta. So the most severe type is this one here, okay, the first one, and the baby's spinal canal remains open along several vertebrae in the back, okay. And now what I think is really clear to show this are the 3 images here. So the first one refers to spina bifida occulta. It's kind of in a different order to what these are, but you can see the little labels underneath to match them up. And then this one here is meningocele, so that matches up to the middle, and then the last one here matches up to the first one. So the images actually help you visualize what's being explained in the words here, which you can read through in your own time. There's no cause in particular of spina bifida. It's more that there's risk factors, and the main risk factor that so many people know of is actually having low levels of folic acid intake during pregnancy, which is why this has pushed so much in modern day pharmacology in terms of pregnancy, in terms of pregnant women, the importance of taking the substantial amount of folic acid. In terms of treatment and management of spina bifida, surgery is probably the most common route to go down in terms of closing where the spine has been left open, and also in treating the hydrocephalus, which spina bifida usually does cause. One important note to mention is that spina bifida usually can be detected early on in a scan during pregnancy. Next we have hydrocephalus. So hydrocephalus is a buildup of fluid in the brain. So fluid in the brain, we're thinking cerebrospinal fluid. Cerebrospinal fluid has got 3 important functions. So it protects the brain from damage, it removes waste products from the brain, and it provides the brain with the nutrients it needs to function properly. So CSF is really, really important to the brain, and it's in the 4 ventricles of the brain, the lateral ventricles, the 3rd ventricle and the 4th ventricle, and it's produced by the choroid plexus, which is present in all those ventricles. However, hydrocephalus is a buildup of too much CSF, and symptoms of this can be headaches, causing you to be sick, blurred vision, and difficulty walking. And it's important to be aware of 3 types of hydrocephalus. So you've got congenital, which is where it's present at birth, acquired, so this develops after birth, and normal pressure hydrocephalus, which develops normally in older people. So think about it, you've got it at birth, after birth, and in older people, in terms of the time that it's developing. However, the most obvious hydrocephalus is in newborn babies because they have those cartilaginous frontanelles in their skulls. It's not quite fully hardened up yet, and so therefore if they're suffering from hydrocephalus, it's going to be really obvious because it's going to push those out, and you'll normally see this in the characteristic image of a baby with hydrocephalus where the head is bulging and a little larger than normal. So if we've said that CSF should be in the brain, if we've got too much of it, how do we get too much of it? Okay, so this can be seen here in the causes box. So it could be caused by either a blockage, so something that's stopping the CSF escaping from the brain as it should do, It could be a faulty overproduction, so you're just naturally producing too much, or it could be a poor clearance. That mechanism is working slower than it should do. Having said that, hydrocephalus is very treatable, and it's usually done with a shunt, which is a thin tube which is implanted into the brain and drains away all that excess fluid. Next is Hirschsprung's disease. So this is a rare condition. It's a congenital problem where nerves are missing to a segment of the bowel, particularly the last segment is usually commonly affected. As you can see in this image here, there's no nerves to this area of the bowel. As a result, the baby is unable to defecate, which causes a blockage. So really the only way we're going to treat this is through surgery. Next, we move on to a little bit of genetics. So the main two we were looking at here are Patau syndrome and Edwards syndrome. So Patau syndrome is also called trisomy of chromosome 13, and Edwards syndrome is also referred to as trisomy 18. Now, there are two characteristic pictures of babies who are suffering from these genetic disorders here. Characteristics, they are quite similar between the two. So, for example, they both tend to have a clenched hand with overlapping fingers. Things that may distinguish them between each of them for you. So, Patau syndrome, we may be looking for them having an extra limb, so polydactyl. You may also be looking for a cleft lip or palate. In babies suffering from Edwards syndrome, you'd maybe be more focused on this heel here, so they'd have flexed big toes and a prominent heel. Haemophilia is another condition that was covered in Foundation Block. This is a condition that affects the blood's ability to clot. So it's usually inherited, especially it's inherited in an X-linked recessive manner. So it is linked through family to family, and most people who have it are male. So obviously normally when you cut yourself you'd expect your blood to clot, and clotting factors combine with those blood cells to make the blood sticky and clot and stop bleeding. So therefore you can imagine the symptoms of haemophilia are the opposite of that. When you start bleeding, it's hard for you to stop, or it takes a long time for the wound to clot. So for example, if you have a nosebleed, that might take a long time to stop. Your gums may bleed more easily than normal, and when they do start to bleed, it's harder to get them to stop. In terms of treatment, again, cure, there's not particularly a cure. However, some kind of treatment usually does allow the patient to live a good quality of life in general. Precautions, if you know you have a family history of haemophilia, it's really worth getting that checked out and making sure you know your risk of inheriting it. A few key points here about the genetics. So this is more linked to X-linked recessive as a general kind of branch of inheritance. However, it's really important to be aware that no son of a man with haemophilia will have haemophilia, but all daughters of a man with haemophilia will be carriers, and they're called obligate carriers. So that's a little bit tricky to get your head around. However, if you think about those concepts, it really does make sense. The best way to do that, I find, is to look at some charts. So the inheritance trees. So if you get them all next to each other, so autosomal dominant, autosomal recessive, X-linked recessive, all the different types, and kind of just look, and you can see the clear differences between them. Next, we've got Huntington's disease. This is the last one we're going to talk about in this video. So Huntington's is inherited in an autosomal dominant manner. So autosomal dominant, that means you've got a 50% chance of inheriting it. It doesn't matter if you're male or female, you've got a 50% chance of inheriting it from your parent. It causes damage to the nerve cells in the brain. So this brain damage can progressively get worse. The onset of Huntington's isn't normally until around 35 to 55 years of age, which is probably what makes it so scary, because you don't actually know you're going to suffer from it until the time comes. There's no cure for Huntington's, and its progress can't be reversed or even slowed down. Medication really is used to help treat the symptoms. So symptoms include personality changes, mood swings, being fidgety, and irritability and involuntary movements. So there's quite a few symptoms of Huntington's, and it's really important to use medication to get those under control. Therapies are also really important, so in terms of helping with speech and language therapy and occupational therapy, which really helps improve also the quality of living for the patient. Join us next time, so part 2 will be coming soon of Foundation Block, where we continue looking at the remaining 6 cases that were covered in that first week of second year. Thanks.